The other form of MI is considered unstable MI with non-ST segment elevation. Okay? The reason they're presenting this differently is because there's different ways of treating this. Presentation is still angina at rest a lot of times, chronic angina that becomes more frequent. Signs are congestive heart failure, mitral regurgitation, ST segment depression, very similar to the other one, except you don't have the ST segment elevation. Okay? You still have ST segment depression, and you may have T-wave inversions. Okay? It's usually diagnosed by elevated cardiac biomarkers. When you're looking at pharmacological treatment, it still requires MONA, okay, beta blockers. But what's really important about this treatment is that thrombolytics are not usually recommended. It's not seem to be helpful in these patients. Still, angioplasty and stents are indicated, as well as open heart. Now, what are the antiplatelet drugs? What do they actually do? You need to know as part of your pharmacology. Aspirin basically decreases thromboxane A2 levels, okay? And thromboxane, of course, it helps the clotting cascade take place. The way aspirin basically works is it inhibits COX-1 to convert PGG2 to PGH2, which then inhibits the thromboxane formation. The bad thing about aspirin is that once you give it, it stays on board for a while. Okay? It's not going to go away very quickly. But the good thing about it is it's such a low-grade effect that it doesn't actually cause you to start bleeding unless you have, you know, a major problem somewhere else. What you're trying to do is you're trying to prevent any more accumulation of a blood clot in the heart, in the coronary vessel, and as a consequence, hopefully stop the MI. Now, platelet aggregation things, part of the clotting mechanism that's very important is that platelets have to become activated. Without platelet activation, if you just get the extrinsic factor or the intrinsic factors activated, which then leads to the formation of fibrin clot is very weak. It tends to break down very easily. Okay? But if you start putting platelets into it, then you make the actual clot very strong. Okay? Usually before you start getting activation of fibrin deposition, you tend to get platelet aggregation as well. Okay? So the first step of endothelial cell damage is that the platelets come around pretty quickly and they adhere to the endothelial wall and begin to release factors which enhance the fibrin formation. Okay? Now, the way the platelets actually work is that they're normally a kind of a discoid shape, and when they're activated, they become almost like macrophages. They extend out feet, okay, so they become more like amoebas, and they begin to adhere to the vascular wall. So you see the little feet out here, and they actually plasters on, and eventually the platelet actually completely spreads itself out and acts like a plug. Pretty neat. Okay? So it almost increases its diameter by about 10-fold. So platelets can be pretty amazing little things. Platelets can also, unfortunately, be damaged by many different factors. Things that will make you hypocoagulable will be like end-stage renal disease. Patients with severe metabolic acidosis, okay, makes platelets dysfunctional. Okay? There's also medications that we give that prevent the platelets from adhering, and as a consequence, the clot is less weak, as it was more weak, and breaks down more readily. Okay? The antiplatelet drugs that you can use are inhibitors of adenosine diphosphate receptors, and they inhibit platelet aggregation, are things like Plavix or ticlopidid, which is Ticlid. Okay? Clopidogrel is Plavix. Okay? So the way these drugs work is they bind and basically inhibit platelet adhesion. Okay? You can also have other kinds of drugs that are platelet glycoprotein 2B and 3A receptor antagonists, which also prevent platelet aggregation, are things like I can never say these words, so I'm not going to say it. Okay? I will sound like a fool. So just put these down. Okay? Those are possible medications. The one I really want you to know is Plavix, clopidogrel. The reason that's such an important agent to us is because with regional anesthesia, these drugs are really dangerous. Okay? You don't want to be putting in any kind of regional anesthetic on somebody who's on Plavix. And there's a lot of people on Plavix now. Okay? The reason that so many people are on Plavix is due to coronary stents, which we'll talk about in a minute. Okay? And you have to know how these stents are going to affect how you're going to deliver the anesthetic. Okay? This is actually how these agents work. By actually binding to these receptor sites, they prevent adhesions to take place and basically block fibrinogen activation. Beta blockers, the principal treatment for angina, it basically works simply by decreasing the myocardial workload. It is not appropriate to give somebody a beta blocker that's in failure. It's not the right thing. You'll read about it in the books, and what they're telling you is that they'll take the person out of failure first and then put them on beta blockers, so they don't increase their workload and put themselves back into failure. But in an acute failure situation, you don't add beta blockers right away. I've seen some cardiologists do that, and I scratch my head and I'm like, what are you guys doing? And the patient gets worse, and they wonder why. You can't do that. Okay? The heart's already maximally trying to work, and giving a beta blocker will just put them in a worse situation. Okay? But in the non-acute setting, beta blockers actually have enhanced survivability, and that's why it's being used so extensively. And very soon for us, because of pay for performance, they're asking us now to actually give everybody a beta blocker prior to surgery. That's really not safe either. Okay? You can go overboard. You got to select the patients right before you start giving people beta blockers. If they're already on a beta blocker, it's perfectly appropriate to do that. But if you give somebody a beta blocker that's never been exposed to the medication, you might end up being very surprised on how too effective it is. Okay? So it's got to be a little bit of a balance. Okay? The Germans have found, they'd done this study a number of years back, and they almost invariably put people on beta blockers prior to surgery, because one of the bad things that happens from surgical stress is that you do release norepinephrine or an epinephrine into your bloodstream. That epinephrine increases heart rate because of its beta-1 effects. So putting a beta blocker on that person helps offset that surgical stress level, which increases the risk for a myocardial infarction. Okay, so beta blocker in that situation is very appropriate. The danger is operatively, when we give anesthesia, we suppress almost everything. We're suppressing the sympathetic system quite well with our general anesthetics. And as a consequence, you can get significant hypotension when you add a lot of beta blockers to people. They do have a decreased risk of death and myocardial reinfarction if you give somebody long-term beta blocker therapy. Contraindications are, of course, severe bradycardia. You can actually make somebody's heart rate almost stop. You can actually put them in complete AV block as well, so don't do that. Sick sinus syndrome is also a contraindication to use beta blockers because you will put them in complete heart block. What always bothers me is everybody forgets this one, severe reactive airway disease. Beta 1s are selective, but they're not completely selective. The other beta that you have in your system is found where? It's in the lungs, called beta 2. Okay? And beta 2 bronchodilates you. Okay? Bronchoconstricts you. Beta 2 bronchodilates you. So if you put a beta 1 blocker and you block beta 2 as well, because it overextends itself, then you can get bronchoconstriction that can get much worse. Okay? And when you give these people epinephrine to try to offset it, you don't get the response. Okay? So be careful with that. Okay? I've seen people who've had very severe asthma, and then they're given beta blockers for their heart, and their asthma only gets worse, and they wonder why. Okay? The side effects also include beta blockers is fatigue and insomnia. Some patients don't really feel very good with beta blockers, and they'd rather be off it. Calcium channel blockers are long-acting and are effective in control of angina. They're short-acting and are not effective in control. The short-acting ones are not effective in control of angina, so we shouldn't be using those. They decrease the incidence of coronary vasospasm, and they basically function by decreasing the tone of the smooth muscle. They dilate the coronary arteries, and they decrease myocardial contractility, myocardial oxygen consumption, and they also decrease arterial pressure. So you're basically afterload reducing them. You're decreasing the contractility, which is increasing decreases the myocardial oxygen consumption. They're contraindicated, of course, just like beta blockers in severe congestive heart failure. You need the maximum amount of cardiac output at that point. Side effects include hypotension, peripheral edema, and some people complain of chronic headaches with calcium channel blockers. Nitrates decrease the frequency, duration, and severity of angina. They're basically preload reducers, which help decrease the left ventricular end diastolic pressure. That's how they mostly work. They're also coronary vasodilators, and because of that, they also help improve perfusion. The downside to them, because they are coronary dilators, if you have an area of fixed lesion, you can actually cause a coronary steal syndrome where the blood is being stolen from the area that's ischemic to an area that is not ischemic. So that's the downside to it. Okay? The reason that most of the time nitrates work is, besides dilating coronary arteries, is more importantly is that they decrease the preload and they decrease the left ventricular end diastolic pressure, which that alone helps perfuse the heart a lot better. Okay? They also decrease peripheral vascular resistance. This decreases the afterload and decreases the myocardial workload, which decreases the isovolumetric contraction energy demands. Nitrates, of course, are contraindicated in IHSS. Remember, you don't want to drop preload in patients with IHSS problems. Severe aortic stenosis is also not a good idea to give nitrates. And you want to avoid, if somebody is on Viagra, if you give them nitrates, you can actually induce a very severe steal syndrome and give that person a significant heart attack. And that's how people actually, I think, do a chemical stress test on themselves. As they get older, they start using Viagra more, and then they start getting heart problems, and all of a sudden we have them in an open heart suite. Okay? Side effects are headache and hypotension if hypovolemic. ACE inhibitors, these drugs are wonderful drugs for long term. Be very careful for short term. They basically work by inhibiting the conversion of angiotensin 1 to angiotensin 2 in the lung. The angiotensin 2, of course, helps in certain ways by it prevents myocardial hypertrophy. ACE inhibitors also prevent interstitial myocardial fibrosis. It prevents coronary vasoconstriction. It prevents endothelial dysfunction, prevents atheroma formation, and prevents inflammatory changes. So that's pretty significant for ACE inhibitor to be able to do all those things. It's recommended for treatment of patients with atherosclerotic coronary artery disease, hypertension that's not renally related, of course, left ventricular dysfunction, hypertension with diabetes. It's really contraindicated in people that are allergic to it. Well, I showed you that before about the airway. So you can get angioedema of the airway. You can lose the airway completely. Some people will actually develop hyperkalemia with it, and it's also contraindicated with bilateral renal artery stenosis in patients with renal failure. It may actually progress the disease even further. Now, what will happen if you have an acute MI? What are the complications? It depends on which side of the ventricle you're talking about. If you have a right coronary artery MI, okay, you're most likely going to get a bradyarrhythmia. Okay, so you're going to have arrhythmias, okay, it's common, but they're going to be slow. So these people are going to come in with a slow heart rate. The other thing they're going to come in with is that their lungs are going to sound completely dry. They're going to sound clear. If the right ventricle is not pumping into the lungs, then the lungs don't fill up with water. Okay, as a consequence, the lungs are dry, and when you listen to them, you don't hear crackles, wheezing, nothing. They sound actually very good. What you will notice on the person's physical exam is that their neck veins will become distended, okay, because you get right ventricular dilation, and you get eventually accumulation of pressures inside the CVP. So you can see right-sided increases in your veins. You can also get congestion of the liver if it's really severe, and as a consequence, you get hepatic dysfunction. Okay? Now, the much more dangerous ones that they deal with is, and most of these problems that you see with the right-sided MI is that you have a low preload state to the left ventricle. Okay? And because the reason is that you're not pumping volume from the right to the left. So the left is actually empty. So these people are dying from hypovolemic shock. In the left ventricle, if we told you that it was dilated, we would tell you to drop the fluids. But if you're looking at the right ventricle, the left ventricle is dying because it doesn't have enough volume in it. So for right-sided MIs, we tell you to give volume. We want you to get volume into the patient so some of it gets into the left ventricle. Okay? Very different treatment plan. If you have an acute MI on the right side, that's a different animal, the left side. That puts you at a much higher risk for developing a ventricular arrhythmia that could be malignant. These are people that develop BTAC, BFib, okay? Complete heart block. Bad stuff, okay? So ventricular fibrillation, of course, is going to kill you very quickly. The new recommendation for ventricular fibrillation is don't even ventilate, go immediately to defibrillate. And actually, most people are telling you when you're doing CPR, do CPR and don't ventilate. Now, I knew that 10 years ago. That study is a long, very old one. It's actually a very good one if you have time to read it. Okay? What happens when you do CPR on somebody, and we used to demonstrate this when I was an ICU fellow, okay, is when we had A-lines in a lot of patients. When somebody would code, we would do CPR. And we'd tell people, don't ventilate. And when we were doing it properly, we would actually see, and we would do it faster than was recommended at the time. Now the recommendation is faster. So you go as fast as you can, as deep as you can. Okay? And what you look at is you look at not the systolic pressure. The systolic pressure means nothing. Why does the systolic pressure mean nothing? Because it has nothing to do with coronary perfusion pressure. Coronary perfusion pressure is strictly ADP. So if your ADP is not coming up, I don't care how good your CPR is. Okay, it's not going to do you any good. So as you're doing CPR quickly and rapidly, that's called stacking. Okay? As you stack the rates up, you'll see that the diastolic pressure rises. And it's almost magical. You can tell when the person's going to turn over. You can watch your A-line and you hit that 50 pressure on the diastolic and the heart flips and starts pumping again. And then you got a pulse again. And then that's when you ventilate. Now the interesting part, what we were doing when we were doing the CPR, is when we would watch somebody would ventilate, as soon as they would give that one breath, guess what happened to their diastolic pressure? Go 0. It went to 0. It was depressing. Okay, you're doing your hard work, you're sweating, you know, it's pouring off you, you're working hard. Okay, and then you see somebody ventilate, and it goes down to 0, and you're back to square 0. Okay, and then you have to do it again. So we found that, you know what? Stop ventilating. In our unit, we stopped ventilating and we drove up the perfusion diastolic pressure up to 50, and then we usually got most people back. Our actual, if somebody coded in the unit when we were watching them, we had about a 90% bring back rate. Pretty impressive, okay, because we changed the way our protocols were done. Now people are now doing the same thing. Okay. Simply positive pressure is very detrimental for the heart that's stopped. Now you have to ask yourself, geez, you know, Dr. Nolan, you're teaching us that, you know, that we shouldn't ventilate somebody. So what's happening to the CO2 levels? What's happening to the oxygen levels in the lung? Well, if you think about it, if I get 0 perfusion through the lung, as I'm doing CPR, what I'm really doing is I'm not really creating that much perfusion to the lung anyways. And my lung has a considerable amount of residual volume of air in there. And because the perfusion is very light going through the lungs, okay, the uptake of oxygen is actually pretty low. Okay, it's going to be whatever it was when you started the code. Okay, so if you want to give a breath initially, give them 100% and you're done. Don't give any more. Now your alveoli are 100% or pretty close to, let's say, 60%. Now it's uptaking oxygen. Now, are you really going to effectively ventilate CO2? The answer is no, until you get perfusion back. So it makes no sense to try to ventilate somebody while you're doing CPR to try to blow off the CO2. It's not going to happen. So don't hurt the patient by trying to, you know, theoretically think that you're going to reverse the acidosis from the respiratory acidosis. You're not. Okay, until you get the perfusion back. When you do get the perfusion back, but don't go crazy and hyperventilate the patient, because that positive pressure can also be detrimental. And what's even worse is if you hyperventilate somebody too rapidly, what happens to their potassium levels? Straight down. One of the treatments for hyperkalemia is hyperventilation. If you're somebody at 4 and you start hyperventilating, you can get them down to 3. And what happens at 3, what kind of arrhythmias can you get with hypokalemia? You can get tachydysrhythmias. Tachydysrhythmias, AFib, atrial flutter. Okay? So you want to stay out of that. Okay? It never ceases to amaze me. I was watching something the other day. I was with some of the students, and we started the case. And as soon as we started the case, the patient started having Gemini. Okay? And the student was like, whoa, that's not good. I said, just relax, stop ventilating. So we stopped ventilating. Okay? What she had done was she was so effective in ventilating that she was effectively hyperventilating the patient. Drove the potassium level down and started giving the patient Gemini. As soon as she stopped ventilating, 45, 50 seconds, CO2 level rises by 4 points for every minute. Okay? And then potassium levels rise accordingly. PVCs go away. She looked at me like, wow, that's kind of cool. I said, yeah, you're hyperventilating too much. Don't do that. Okay? That also can cause problems. All right, now, hypokalemia, of course, is not your friend. Okay? VFib is not going to be, some of you want to reverse the hypokalemia. Lidocaine is another thing that you may consider. Amiodarone is first-line treatment pretty much nowadays for most people for VFib. VTAC, unstable VTAC, is different than stable VTAC. Stable VTAC means you can chemically reverse it, okay, which most of us would rather do chemical reversing of effects than to do electrical. Electrical frightens most people. It still frightens me. I don't like putting paddles on people unless I have to, okay, because then if you put a paddle on somebody who's got some kind of rhythm and you shock them and they go into VFib, then you're like, whoa, that's not what I wanted to do, okay? So stable VTAC is very different than unstable VTAC. Unstable VTAC means that you're losing your pressure. Stable VTAC means you got a blood pressure. Okay, so treat one with medications, the other one you treat with electrical cardioversion. This is not the same as a defibrillation. This is a cardioversion. If you don't know what the difference is, make sure you talk to me later on and make sure that we can go through that as part of your ACLS protocol. Okay? You know, we have to be the experts in the operating room. There is nobody out there that's going to come in and help you. Okay, there is no ER doctor. There's no ICU doctor coming back to the operating room when there's code happens in the operating room. You're it. So if you don't feel comfortable with resuscitating somebody, you better start getting comfortable. Okay, we run all the codes. The surgeon does this. That's his involvement. Or you ask him to cross-clamp the aorta, you can do that too for you. But he won't do it unless you ask him. Okay? So you have to take charge in this situation. Call for help, of course, and then start running your protocol like you're supposed to. Okay? One of the most common atrial dysrhythmias post-MI is atrial fibrillation. Okay? It has to do with several reasons why, but a lot of it has to do with the way potassium is being changed rapidly. Usually hypokalemia is a big enemy. And then you can also get bradyarrhythmias from right ventricular ischemia. Acute MI can then progress into pericarditis, mitral regurgitation via ventricular septal rupture. That's always a bad day. When you get a ventricular septal rupture, most people don't survive. I had one patient that we put on an induction. It was one of my friends. I was there helping him. And as soon as we gave the patient etomidate, we lost all our waveforms. We lost our A-line, we lost our pulse oximetry, we lost our end-tidal CO2 when he intubated him. And sure enough, the guy's ventricle had actually ruptured open during induction. He didn't have a pericardial effusion. He actually had an MI, which then blew out the ventricle wall on induction. So it may appear like pericarditis, but it actually is not. So myocardial rupture is a devastating complication. You're not going to get anybody back. Had another case like that where we transported a patient back to the operating room. And one of the things that I want you to always know is that if you're doing a sternal flap, which means that you're taking the sternum and removing it because it's infected, okay, you don't ever transport those patients unless they're muscle relaxed. Okay? If they're not muscle relaxed, what will happen is a person, when he's moved from one bed to the next, they will cough. Okay? And if the sternum's already gone, what are you left with? Ribs. And ribs are sharp. And what happened to this patient was and I asked them to muscle relax the patient, they forgot to. Okay? They transfer the patient over to the room. Then I get called stat. When I arrived, the blood was just gushing out. I put my bare hands onto the guy's chest, and the blood was so powerful that it was pouring through my fingers like I couldn't hold it. Okay? So what happened was the surgeon opened up the chest immediately. The ventricle was cut in half by the ribs coming together. So it cut them like scissors. Okay? So make sure that you listen when people tell you muscle relax somebody. That's the reason you do it. Okay? Right ventricular infarction, of course, is different, which we talked about that before. And then you may also develop increased risk for strokes. The reason being is that when you develop acute myocardial infarction, the muscle begins to stop working properly, and you tend to form clots on that side. And as a consequence, if it's a left side of MI, it will tend to break off the clots and go to the brain. Okay? Perioperative MIs are not, the incidence is not 0. You can look at that number. That's a pretty big number. It's almost 1 million people worldwide. That's a lot, but if you think about it from the standpoint of how many anesthetics are delivered per year, it's less than about 1%. Okay, so it's not real high, but it's still something you've got to be concerned about. I think they made this number just look pretty impressive. That's in the book. Most are seen in the first 24 to 48 hours. The risk that you see is perioperative medical condition. If the patient's got significant disease beforehand, certain kind of surgical procedures increase the risk. It's not so much the anesthetic, it's the actual surgical procedure. If you're going into the chest or the abdomen, risk goes up. If you're going into the legs or knees, okay, arms, the risk goes down. If you go into the brain, the risk goes up. All the major vital organs increase the risk for the myocardium to develop ischemia. Okay? The faster the surgeon is, the better it is. The less bleeding you have, the better it is. Okay? So if you have somebody who's sloppy and too quick, but it makes a lot of bleeding, you're not doing any favors. Okay? Diagnostic criteria are sometimes difficult, EKG, post-op, and other stuff, but the overall medical care is also very important. Most people don't die immediately post-op. When do they die from an MI? Day 2 and day number 3. Okay? The reason day number 2 and number 3 is because the actual heart, okay, when you cut somebody, you cause a lot of third spacing to take place. All the volume that you guys are going to deliver in the OR is going somewhere. Okay? We teach you in clinical to give 3 cc's for every 1 cc of blood loss. Why do we tell you to do that? There you go. 1 cc stays intravascular. The other 2 cc's is into the interstitial tissue. So if I give, let's say, somebody 10 liters of fluid, okay, that means 3 liters are going to stay intravascular, and the other 7 liters are now the interstitial space. That's not magically going to go away. It's going to come back, but it doesn't come back the first 24 hours. The reason it doesn't come back the first 24 hours is because the incision has caused an inflammatory reaction to take place. And when you cause an inflammatory reaction, you cause the capillaries to stay leaky. So they're still leaking fluid out of the vasculature. After about 24 hours, the inflammatory system begins to shut down. And once it shuts down and seals the capillaries back up, it starts sucking that extra fluid into the interstitial space. Now you have to ask yourself, why does the body do that? You know, why would it do that? I mean, because if you think about it, in the sense of if we were walking around in the savannah, okay, and Mr. Saber-toothed tiger, I know they didn't exist at the same time as a caveman, but it just sounds so much better, okay? He comes around and slaps you in the back and makes a big cut on your back, okay? Now you're hemorrhaging, you go into shock, your blood pressure's low, okay? But all that fluid just keeps leaking out of your blood vessels. There's no advantage for survival for that to continue. So the best thing to do at that point is for the inflammatory mediators to suck your plasma into the interstitial space and hold it there for you for a little bit until all the clotting stops. You're bleeding. There was no reason, there was nobody putting an IV in you when you were in the savannah and your back was hemorrhaging. So that never happened. Okay? So if you survived the first 24 hours, now you had a little excess volume in interstitial space, so now it would get pulled back in and you would be okay. You survived the event. But what happens in the operating room is that we resuscitate them very effectively. We take them out of the shock very quickly. The danger of it is that we leave all that fluid in the interstitial space. And the danger of it is post-op day number 2 is that fluid now is going to get removed. The capillaries start pouring the fluid back into the blood vessels. Okay? It starts sucking the water back out of the interstitial space. And now instead of having the normal blood volume, let's say of 4 liters, Now you're up to 7 liters, and your heart's having to work harder to push that around to get it to the kidney to get rid of it. So you know what's happening because you look at it in the ICU. All of you have seen patients in the surgical ICU. On post-op day number 2, they start pouring out 500 cc's every shift, excess fluids. The reason that's happening is because intravascularly, all that fluid is being sucked back in, but that's making the heart work harder. It also dilates the heart, which makes the left ventricular end-diastolic pressure go up, which then puts the person at more risk for coronary perfusion problems. Okay? So that's why people develop MIs. So when people tell you, you know, that you have what I call the drowners and the dryers. Okay, those are dogmas. Some people tell you to dry the patient so much when the patient comes back out of the operating room, give me something to drink. I can't, I'm so dry. The guy's like, I'm in the desert for the last 3 days. Okay? That's what I call the dry people. That's not what you want to do. You don't want to make somebody so dry that they're uncomfortable post-op and they're actually hypovolemic. That's not really the best treatment. On the other hand, you have the other people who say, it doesn't matter. I give all the fluids I want. Nothing happens. And they drown everybody. Everybody gets 3 liters by the time they finish. Even if it's just a tail, removal of a toe, they get 3 liters. You can't do that either. Okay? You got to be in between somewhere. Think about, and you trust me, you'll see somebody who does it every time. We actually had some person that was doing that so much every time that in day surgery that we actually have micro drips now. And guess what? We've had congestive heart failure since about 3 years now. Okay, so because one person just kept giving everybody 3 liters, no matter what you did. You told her not to do it. The good thing is they're not working here anymore, but I'm just telling you, you'll find somebody that will do that in your practice. Okay, you'll find out that they have constantly somebody going to the ICU because they're putting the patient in failure. Okay, now, what do you do here? Okay, surgery is an inflammatory response. This was what I was talking about before. It causes a hypercoagulable state. This increases the risk for thrombosis and embolus risk. You can also have a plaque rupture that can occur, and all these things can eventually lead to decreased oxygen delivery and perioperative myocardial infarction. The neuroendocrine response, which I was talking to you about, also puts the person at increased risk. One of the things that students sometimes forget about is shivering. Shivering is really dangerous. Okay? Shivering increases myocardial workload by 300%. Just think of that. That's like me taking you outside and making you sprint. And then the next to you is like, how do you feel afterwards? Feel a little nauseous, Dr. Nolan. Don't feel very good. Okay? And that's how these people get. Okay? If you make them shiver, what are they going to start getting real quick? They'll start getting nauseous. You're making them so lactic acidotic that they're not going to feel well. If you have open heart surgery and somebody's shivering immediately post-op, you know what you do? Muscle relax them. Let them wake up later. Do not let somebody stay in shivering. You will cause them to have an MI. Clinical predictors of increased perioperative risk are major, intermediate to minor. Okay? The major ones are the ones that are things like unstable coronary syndromes. These are patients with acute or recent MI, okay? Unstable severe angina, decompensated heart failure. If a patient has significant dysrhythmias, puts them at significant high risk for patients with high AV block. You should really be putting these people on a pacemaker before you take them in the operating room. I had a cardiologist tell me the other day that he wanted to put the pacemaker after we were done. And my answer to that, like, what? And he goes, I take it that you want the pacemaker first. I said, yeah, we're going to do that first. And boy, was I glad. As soon as we put the patient to sleep, he went into complete heart block, and the pacemaker took over. So that would have been a bad situation to be in. I've been there before. I've thought that I was gung-ho, slapped around a little bit. I learned, you know what, don't do that again. Okay, if you have somebody with significant dysrhythmias, don't take the risk. Put a pacemaker in them and move on. Okay, so the cardiologist is happy anyway. He gets put a pacemaker to somebody else. Okay, severe valvular disease also can cause significant problems as well. Intermediate risk, you're looking at mild angina, prior MI with Q waves on EKG. If you have compensated previous heart failure, diabetics, or renal insufficiency, all give you intermediate risk. then the minor risk is advanced stage. Most people that hit 70 and are older are not going to die from MI most likely. That kind of strange statement, isn't it? Why? Most people with advanced coronary disease die between the age of 50 and 70. Isn't that frightening? The reason being is that most people after 70 have a lot of other, we call it collateral flows, okay, for one thing. And the other reason, too, is that they've decreased their activity, so they don't have a lot of concomitant other diseases. Okay? If you have somebody who's been smoking for 50 years or 40 years, 50-pack year of smoking, and they're morbidly obese, they're going to be dead at 60, 65. Okay? If you're thin, healthy, running around, you have a little bit of atherosclerotic coronary disease because you eat steak every once in a while, it's okay. Then might have an MI at 70. You might still survive the MI because your heart doesn't have to work because you're morbidly obese so much. So you'll survive that, and you'll be in your 70s. You'll still have disease, but you'll be maximally medically treated, and you should do okay most of the time. Okay? It's the people that there are multiple stuttering infarcts and other things that are getting into trouble constantly. Now, I can tell you the degree of ability that we have is tremendous now. Okay? Dick Cheney, you guys all know who he is, the ex-Vice President of the United States. He got an LVAD put in him just about 3 months ago. You know what an LVAD is? Left ventricular assist device. Okay, so now because his heart was failing, they actually put an assist device on him. So now he actually can do normal activity, and he actually just has a power pack that's with him all the time, and he can basically do pretty much normal stuff. Now, will it give him a long life? The answer is no, but it'll give him enough time to bridge him for a transplant. Okay? Now, you have to ask yourself, why is it that we have so much capability in the hearts? And I'm not going to be cynical, I'm just going to tell you the fact, I think. Okay? The reason that we have so much capability for taking people's heart is that the politicians that we have are old, okay, and they're going to make sure that this area is funded very well. Okay? So when you have to have your LVAD, you can get it done. Okay? And you get your heart transplant. No other country in the world would actually put an LVAD in somebody that's 74 years old and then bridge them for a heart transplant. Doesn't make sense. Okay? The 20-year-olds are not getting the heart transplants that they need, that are cardiomyopathies. So it's just the way it is. Okay? But we have a lot more capability than most countries now do when it comes to heart disease. Okay? We are able to do stents. We're able to do things that people would dream of, okay, in the past. The other thing that's minor risk is for history of strokes, low functional capacity, uncontrolled systemic hypertension, still considered a minor risk. The things that I want you to really know is this one. Okay, this is always asked on exams and boards. Okay, if you had an MI that's less than 6 months, you really shouldn't take the patient to the operating room. The risk is way too high. Okay, so if you have somebody who's had an MI 6 months ago, you should wait at least 6 months. If you're under 3 months, the risk of having a reinfarction or other injury is around 37 to 27%. Now, here's what I want you to know, and this is how bad things get sometimes in medicine. Rao is a bad news person. If you ever read anything from Rao, dispense it out of your mind. It's a waste of time. Okay? He faked all his data. He faked all his data. Okay? So when we were first taught this in medical, in my training, we were told that the new gold standard was Rao. Okay? Goldman was pretty much a cardiologist who stated that if you put a patient in the operating room under 3 months, the risk was 23%. Rao came back 5 or 10 years after that, okay, and came up with this incredible number showing that at 5.8% risk. And this is what caused the effect of massive utilization of PA catheters. Rao demonstrated that if you put an A-line in somebody, epidural for controlled pain, and then put a PA catheter to monitor pressures and optimizing cardiac output, that you could reduce the risk of somebody having an MI under 3 months to 5.8%. So guess what everybody did? Everybody bought a PA catheter. Everybody bought an A-line. Everybody bought an ICU stay before surgery. And then a few years later down the road, just about 4 years ago, we found out that Rob was actually making up all the data. And the reality is it's still 23%. So everything magical about a PA catheter doesn't work. My answer to that is that really true? My personal bias is no. If I put in a PA catheter and I know how to use a PA catheter, I know that I can reduce risk. I think that, at least, okay? Versus most people, when they put a PA catheter, have no clue how the PA catheter works. It's just a little magical instrument that I put in them, and it's life insurance for me. It doesn't work that way. You have to know the technology for it to work. Okay, so I think it's somewhere in between these numbers if somebody ever does a study again. So people, you know, I don't think it's going to happen because now PA catheters has gotten this huge bad rap because of this guy. Okay? 3 to 6 months, it's still around 8%. That's what the magical number people still use. And after 6 months, the reinfarction rate's around 3%. That's the best you can be. Okay? So really wait 6 months. The answer to that question is, if somebody tells you, should you wait 6 months if you had MI, the answer is yes. Yes. Most people, yeah, use the Goldman percentages. Okay? Most anesthesiologists don't like Goldman's study. Okay? Because when he talked about the ASA standard, which is what we use for grading risk, he basically didn't give us he misquoted what ASA standard for. So a lot of people take issue with that. The study seems weak to us, but you know, if you look at Tarhan, that was the original. He was a surgeon that did this, and I think I have to look at who Tarhan was again. I think he's a surgeon. You can see the numbers are pretty bad. It's showing the first 3 months. So you really shouldn't do elective surgery. Okay? So delay elective surgery 4 to 6 weeks after coronary angioplasty, 6 weeks after your bare metal stents, 12 months in patients with drug-eluting stents, okay? And this allows complete endothelialization of the stent and completion of the antiplatelet therapy, such as Plavix. Now this is actually recently changed, and I'm going to show you what we're going to talk about next. Okay? The factors that increase the incidence of reinfarction are greater than 3 hours of intra-abdominal or intrathoracic, blood pressure that's less than 30% of baseline for greater than 10 minutes. That's a pretty high standard. Okay? We have a hard time maintaining a blood pressure at baseline, and that includes patients that are severely hypertensive before surgery, which is really something that's happening much more frequently now. If I ask the question, I guess I'm going to ask it as a rhetorical question. How many people in this room actually have a general practitioner? Okay, about 4 of you. Okay, 5 of you. Okay? The rest of you do not. If you went to Europe, what do you think the percentage of you to have a general practitioner assigned to you? 100% almost. Okay, so it's a very different kind of treatment modality, right? One is preventative, and we have gone to treating all the problems after the fact. Okay, that's why they're able to treat people much more cheaply, because preventative actually is cheaper to manage. Now the downside to that is what I'm trying to tell you is that most patients that come through the door, do they have a GP? And the answer is no. And the problem with that is that hypertension tends to be poorly controlled. And you have a lot of other concomitant problems that when you have to take care of it, something that could be taken care of easily, now you have nobody to call. Okay? And you got nobody to take care of the problem beforehand. And I can tell you during season, when you ask a general practitioner to see somebody, it's impossible. Okay? You'd have to get a cardiologist to see somebody with a specialized consult for them to start treating that blood pressure to bring it down. And that's not what you want. General practitioner would be taking care of blood pressure, not a cardiologist. But that's what you have to do to get things taken care of. Preoperative medications, beta blockers, and nitrates are things that you have to be careful with beta blockers. Nitrates we don't give before surgery. Okay? Do not give nitrates before surgery. You will get yourself into more trouble than it's worth. Okay? Every time you give nitrates to somebody, you will preload reduce them and get yourself in worse trouble. So when the cardiologist says give nitrates, we never do. It just doesn't happen. We know what will happen when you put propofol and nitrates together. You won't have a blood pressure. Okay? We'll stop here and then we'll continue.